So we will try to understand the cancer, various cancer types, how they are named, what it means. It's a lot. And then we look at the epidemiology means where, in which parts of the world, what are the cancers and which ones have more, which ones have less. A little bit about India. I put in some data. So that's the agenda for this particular. Um, so there are four types of main types of cancer, four main types of cancer. If I had to classify everything, all the cancers, then I will, the four major types of cancer that I showed you in that particular table, they come from their different, origins. But the names for those four types, the names for those, here, let me admit two more people. So the names of those are based on where it originates. And so we saw that there was some from blood, some from epithelial cells, remember? Then there was the brain. And so overall, we can now classify. So these are the common names. These are your take-home names that you should memorize. And that is your carcinoma, sarcoma, leukemia, and lymphoma. And what do they all individually mean? All right, so by the end of this talk, you should feel more comfortable to name them individually. So a cancer that is carcinoma is because it starts from the, skin tissue, skin or tissue that covers the surface of an organ. Anything that covers the surface of an organ, it's called as epithelial cell. So your heart has a covering, your liver has a covering, your kidneys have a covering, everything that's a covering, it's called as epithelial cell. So that would be called as a carcinoma. Then a sarcoma is that which is from that, remember I said that they are from cartilage, fat, muscle tissues, bone. So that would be called as a sarcoma. And the sarcoma is really all your connective tissue. So they're like more like soft tissues. And that originates from the blood, is called as leukemia. And so those are cancer of the blood, but it can start from the bone marrow, but it's cancer of the blood. Oops, sorry. Cancer of the blood. And then we have a lymphatic system. Does everybody understand that we have a lymph nodes? We have lymph nodes. You have them under your armpits. You have them at certain locations, lymph nodes. And that is cancer of the lymphatic system would be called as lymphoma. So four in total: carcinoma, sarcoma, leukemia, and lymphoma. And the fifth one that we're not going to talk about so much is the central nervous system. And I showed you one picture of glioma and all that. So that was just it, really. And that's the central nervous system cancers. And so we're back to that table again, just so that it helps you to remember. And here I just made note of something else, is that again, this is epithelial here. These are all connective tissue. This is all the brain, and this is all the blood here, blood and lymphatic system. And so origin and, the stage, what would be the stage be, whether it's benign or whether it's malignant. Benign ends in a oma, okay? That means we're still safe. The it's You don't have to call it a cancer as long as you can just by surgery just take it out. But the minute it starts to invade, then it would be called as a sarcoma or a carcinoma, and here the rest. So in epithelial, you see this word ductal or glandular. So those are those that secrete, like they secrete some kind of a fluid. So they will secrete, let's say, sweat, or in your mouth they secrete saliva, or or the secretion of breast milk, in the breast. So this is glandular or ductal. Okay, so that means that kind of a tumor will also start, will be glandular. It can support itself, and it can also, secrete. So let's look at carcinoma. So we're going to do one by one. So let's look at carcinoma. So today you should be able to, um, differentiate between them. And when you read literature, you should be able to tell those differences. So here right now I am at, let me just make this a red color. There you go. So you're able to see my, so let's look at, carcinoma. And in carcinoma, like we said, it begins in the epithelial cell. Where is that? That's again on the surface of all the organs, okay? Surface of all the organs, of all the internal organs, okay? So lung, colon, pancreatic, breast, etc. And so here we are. And so this comes in, this can be of various types. It will be either a basal cell carcinoma, for the skin. It can be squamous cell, like in the mouth, oral cavities, or cervical, and transitional um, carcinoma, which is typically in the, in kidneys, etc. So no need to go into all that details. The bottom line is that the subtypes are that there's a adenocarcinoma. So let's look at this one. So this is an adenocarcinoma here. What is an adenocarcinoma? Number one, we said that it can break through. So look at this diagram here. This is in the lung. It's an adenocarcinoma, and these are the lung alveolar sacs. So normal. That's very normal. All the yellow one. The red one is the adenocarcinoma. What does it do? It can break free. It can break free, and so it's called as the adenocarcinoma. Versus the squamous cell carcinoma that is in the lining of the bronchus here. It's lining on the bronchus. So a different type, just a different location where there's squamous cells. That's where it would be squamous cells are carcinoma, and the adenocarcinoma where it is going to secrete stuff. So it's going to be in the alveolar ducts here. So why are we showing you lung? Because lung is one of the very strong cancers. I mean, bad cancers, deadly cancers, let's say. And so the other one example I want to share with you is adenoma. So here, adenoma, see this adenoma here, and the other one is carcinoma. So one is benign, one is malignant. So adenoma versus carcinoma. So an adenoma means that it will develop in the glands. Which glands? Like, the sweat glands. Uh, so anything that is secretes, anything that secretes enzymes, etc., etc. So anything that secretes the fluids. So that's where the adenoma will be. And the carcinoma is again on the tissues. The carcinoma will be malignant and the adenoma will be benign. Now, important for you to note that the adenoma can affect anybody at any age. That means children can also have adenoma. You hear that? So children can have an adenoma, but a carcinoma is rarely in a child. Oops, sorry. A carcinoma will be rarely in children. So I'm down here now. Carcinoma a carcinoma will take place because we just saw in the previous section, mutations have to take place, the environment, genetic, epigenetic changes have to take place. So it takes a while. It's going to take a while. So that's why this is rarely in children. Okay, so that was carcinoma versus, so all of the, we just talked about those are the epithelial, and that's the majority of your cancers, okay? Majority. So students, are you able to understand me? Should I speak a little bit slower? Should I go slower? Any feedback, anyone? No? So let's go to the next one. Let's go to the next one, which is a sarcoma. So sarcoma is in the it can be in the bone. Okay. Oh, sorry, you have to change the color now. Let's see. It can be in the bone. So you see this here. It can be in the bone or it can be in the cartilage. And so if it's not in the bone, the rest we just call them as, like soft tissue. So soft tissue sarcoma. So two types, bone sarcoma and soft tissue uh, s- um, sarcoma. So where is that? So this one, if you look on the right hand side, again, I'm making you try to just make sure that you are able to follow this table. So the bone, so the bone here is this one. So osteosarcoma, like bone and sarcoma. I hope this is visible. So that would be, bone sarcoma, but the rest would be cartilage, fibrous tissue, etc. Those would all be called as soft tissue sarcoma. Okay, so this is all connective tissue. So they are very undiagnosed. Soft tissue carcinoma, the problem is that they're not very well diagnosed, okay? And because they can be in these soft tissues and anywhere in the body, and unless they really cause pain, it's just hard to diagnose them. So the patient will complain of a painless lump. Okay, they will complain of a painless lump. All right. And only when it increases in size, really, then it will press against the nerves. All right. So in a soft tissue sarcoma, so for these ones, these fibrous tissues, these will all lead to pain only when it really goes and hits the nerves and the muscles. All right. And that's when they can help cause difficulty in breathing and they can cause general discomfort. And so, therefore, that's the clinical diagnosis. But otherwise, until it gets bad, it's just hard to find or to diagnose. Okay. And so sarcomas are not very common, but they are rather less. They are really just 1%. Um, and so not only, adults, but also young children can also are able to be affected by this condition. Okay, so when it happens. Okay. So amongst the carcinomas, amongst the cancers, this is consistent of typically a little bit low in numbers. So now let's talk about the next one. So we did two of them. So now we talk about leukemia. So now we talk about leukemia. And leukemia, it is a blood cancer, but it will start in the bone marrow. Okay, it will start in the bone marrow. So it will start in the bone marrow because that's where you have blood forming tissue. Bone marrow is where you're forming all that bone marrow. And so therefore that's where it will start. And so it will then release these abnormal blood cells because they're just not, these lymphocytes, these abnormal blood cells, they will just be released. They'll be made by the bone marrow and they'll be released. And so they enter the blood. And that's your leukemia. And so of ages of all type, children of young age, look at this, 0 to 5. Very young children under the age of 5 can be diagnosed with it. They can be diagnosed at slight teen years and adults. And adults. So all the way up to the age of 60 and beyond. So there are four major types, okay? Four major subtypes if you look at it. So number one is lymphocytic leukemia. Okay, lymphocytic leukemia means these are the lymphocyte cells, and lymphocyte cells are too many, so it's leukemia. Okay, and so that can be then acute or it could be chronic. So you can have um, acute, or it could be, serious, or it could be slow growing and chronic, and you can kind of like watch it for a while. Okay. The other one is myeloid leukemia. It's also a blood cancer, all right, but it is from the myeloid tissues. And so therefore that means it can be, let me see if I have another slide for you for that. It can be from some of your, I keep showing this slide to you know. So it can be from these other cells that are, I have another comparison, hold on. So it can be from these other cells that are also in the bone marrow, but they make your white blood cells. So that would be your myeloid leukemia. And in myeloid leukemia, so these are all really kind of like they're all circulating in the blood. And that can also be acute and it can be chronic. So essentially, you have acute, the four major types. Okay, then there are really, really all other ones from there. So lymphocytic leukemia and myeloid leukemia, and then uh, and in adults, this lymphocytic leukemia can be mostly chronic. In adults, it's called a CLL, and in adults, that's very common. So that's very common. But unfortunately, in children, you will have this acute lymphocytic leukemia. So acute, so again, lymphocytic leukemia, but the acute one. So in adults, you will have, sorry. So in adults you will have the chronic one, but in children you had acute lymphocytic leukemia, ALL. Very common in not very common in children. If there was a childhood cancer, then that is the very common childhood cancer. So about 30% of childhood cancers are leukemia. Okay, there are other cancers too, but this one is the more common one, 30%. And the beauty is that as of today, acute lymphocytic leukemia, if it is diagnosed in a child less than 5 years old or less than 10 years old, it is very highly treatable. So the good thing is that it is treatable, and about 95% of those treated all recover and lead a normal, fairly normal life. So, treatable. I don't know if it's curable, but it is treatable. It can maybe recur after 40 years of age, but so this childhood leukemia, at least in Western countries, it is very pretty much treatable, and that's the good news. Okay. So most of the anything that happens in children in childhood leukemia, whether it is lymphoblastic, like I just said here, or lymphocytic, it is mostly acute. So children will have the acute ones. So in children, the treatment cannot wait. So in children, the treatment cannot wait. It is acute. It is going to get severe. It's going to go really fast. So the treatment cannot really wait for the kids. So let's look at a little diagram I had for you here. So in leukemia, you have these abnormal kind of like cells that just don't do the right function in the blood, and we'll look at lymphoma in a bit. And you had these myeloma cells that are white blood cells, and they just don't do function well. And so we'll look at they're special cells that just don't in the blood, again circulating, but just don't do function. So again, I'm going to go back to that diagram in a bit, okay, in a second. So what is the difference between lymphoma when you hear the word lymphoma and then you hear myeloma? All right, so they are both blood cancers. Okay, so let me just show you that table again. Where's my table? So here in blood, you see this table at the bottom, remember? Well, here I'm at the bottom here. So here there was blood and So there was lymphoma and there's leukemia here. All right, so able to go to the next slide. So lymphoma and myeloma. Again, did I show you the myeloma here? So the myeloma, I just want you to pay attention here that myeloma here, see this? That's in the bone marrow, right? This is in the bone marrow. Everything starts in the bone marrow, but it'll go into the blood. So this is myeloma, and um, they are really, at the end of the day, they are a blood cancer, and this is leukemia, and this is lymphoma. So just trying to tell you the differences between them. So a lymphoma and a myeloma, these are blood cancers at the end of the day, but so where does a lymphoma start? A lymphoma starts in the lymphatic system. You know those lymph nodes you have under the somewhere near the neck, underneath the armpits, etc. So they have lymphocytes in the lymphatic system. And so these are where will they start? They will start in the neck, chest, and they will affect the immune system. But the myeloma, on the other hand, they are in the bone marrow. They are plasma cells in the bone marrow, which make antibodies. So can I show you this diagram? Go back to this diagram. And I just wanted to say that here in the myeloma, so this is a B cell, and these B cells make your antibodies. That's their job to make antibodies so that you do not suffer from in other infections, etc. And so when they just don't work anymore properly, then they're damaged. That's what happens. So let's go back to the diagram here. So this myeloma in which you cannot make proper antibodies anymore, all right, that's its job to make those right antibodies. So this you have these plasma cells that just don't function properly, and therefore it's a blood cancer. And so where do they go? They will go everywhere. They can go to the bones, they can go to the kidney. They will just affect the whole body. And so if it goes to the bone, it'll cause severe bone pains and fractures. Okay, so let's take a look at lymphoma in the meantime. It's in the lymphatic system, and so it affects more quickly the lymph nodes, the spleen, and then the bone marrow. And it can also start in the stomach because the lymphatic system is everywhere, so it's in the intestine. So it can also these these abnormal cells can also affect the stomach, intestine, and the brain. So in a myeloma, so now you see that they are really both kind of like blood cancers in a way. So to give you some perspective, a lymphoma from the B cell means that these are the B cells that came out of your, they are, kind of like abnormal B cells. And so this is called as Hodgkin's lymphoma. So it's all circulating, correct? So it's Hodgkin's lymphoma, it's circulating, and there's another one, so this is not very aggressive, but there's one called as non-Hodgkin's lymphoma, and I'm sure you've heard of this. So in a non-Hodgkin's lymphoma, all the B cells and the T cells of the lymphocytes, they're all affected. They are all cancerous. And so non-Hodgkin's lymphoma, see here, the survival rate is 65%. It's not many. It's a bad survival rate, okay? So non-Hodgkin's lymphoma is much more aggressive. And look at the survival rate of a myeloma. A person which have multiple myeloma, we're not getting to get into the details, but multiple myeloma, again, starting from the bone marrow, but these are your plasma cells. The survival rate is 60%. So 60% survival rate in over 5 years. Okay, so that means there is a good amount of death in these. Okay, and T cell lymphoma takes place on the skin. So let's just ignore that for the while. So central nervous system cancers. So brain cancers. So in brain cancers, they just start from the brain and the spinal cord. Okay, so I put in this picture in here because somewhere somehow it's going to be easier to understand with this particular picture. But the brain has, the central nervous system has these various kinds of cell types. Okay, what are they? These are astrocytes. You don't need to know all these names, but these are all supporting kind of cells, and so they are called as glial cells. Glial cells are, they surround the nerve cells. So these are all glial cells. They're support cells, and they help the nerve cells to maintain their functions. So these are all central nervous system cells. So if there is a abnormality here, if there is an abnormality in any one of these four types of cells and it becomes cancerous, it becomes, sorry, a tumor, let's say a mass, then it forms a glioma, and it grows and it forms a bigger tumor. And typically it's more in the front part, okay? So it can grow and it can press on the front part of the brain, or it can press against the spinal cord as well, at other locations if it presses. So that's your glial cells. And so then this is called as a glioblastoma, okay? It's called as a glioblastoma, and it's a type of, so the astrocytes here, that's the one that gets uh, is the cancerous type, and so it is a malignant one, and that's called as the glioblastoma. So a glioblastoma is a brain cancer. And just for you to know, everybody, have you ever heard of the uh, gray matter and the white matter in the brain? Have you heard of that? So a gray matter and a white matter in the brain is, this is all a part, right? So a glioma, just remember that the glioma starts with a G, so it's within the gray matter. It's a part of the gray matter. So it's really the cancer of the gray matter here. And so, not to scare you any further, but this is just to show you that not only do you classify the brain, all the cancers based on tissue of origin, where it started, not just this, but you can have certain features of the cells, histology, some cytological features of the cells. Then are they differentiated? Are they mature? Are they immature? And then how do they behave? You know, are they benign? Are they malignant? So you can combine all of that and you can have all this big, huge table of classification. And this is not to scare you, but just to say that if you were able to see this tomorrow, you should not be scared, and just see that, there are those cancers that come from the epithelial, from the three layers, ectoderm, endoderm, and the mesoderm. Same thing, okay, just more detailed. And those that are from mixed lineages, all right, those are from mixed lineages, which their they have like different types of what is it? They have different types of properties. Okay, so they could be like a germ cell, and so I will not talk about this one, but and then they can have their behavior can be that they can be benign or they can be malignant, and so those that are all kinds of different differentiate states are here. So when you see this, you should not be scared. It's really just a breakdown of all the simple things that I just said before. Okay, alrighty. So that's pretty much it. So let's go, and just to give you an example. Okay, just to give you a all right, somebody is waiting, but nobody has let her in. Anamika Mojumdar, I will let you in. All right. So the pathologic So in breast cancer, we are not talking about it right now, but I think we will talk about this in metastasis. So all these cancers can be staged. So there's stage 0, stage 1, um, and stage 2, 3, and stage 4. And so just showing you in for breast cancer the way that the way that it works, or for most cancers, is that stage zero is a pre-invasive. Stage zero simply means that it is not a cancer, so you cannot call it a cancer. So this is stage zero is where everything is contained. There might be just a couple of dysplastic cells, so maybe just a couple of abnormal cells. And in stage 1, there is the visibility. You do see a small tumor, and so it can be a very low stage, like a low stage tumor, but it is still not, stage 1, stage 2. So in stage 2, it is slightly going into the ducts. Okay, it is entering into the ducts, but it is still, controlled. It is still you know, um, not high grade. It's still not metastasis. It is still not metastasis. It's not high grade. Stage 3. It is still contained in the ducts. It is just in the ducts, so it is still kind of like in situ, still control, still in the ducts. But in stage 4, you can see that it has spread to the lungs here. It has spread this one to the liver here, and it spreads to the other tissues. So really, stage 4. All right, stage 4 is where we can call it as and we'll have different names for it. So stage 4 is the one that is really in metastasis. Okay, so this one is in metastasis, and it is cancer. So here there is still hope that in all of these cases that there is treatment possible, and that there is no that the person can survive pretty well and respond to therapy. So we will do further staging and more words to this in lecture 3. So now we will go to and we will talk about you know, some of the risk factors of cancer. And I think I will, and then, but really more about where is it found, and what is the burden of cancer you need worldwide. And if the risk factors, if we go with the risk factors, maybe at some point, we can leave the risk factors. I can leave for you to read and to, read that on your own, but let's just try our best. Pooja, do you know how much time I have left?
Ma'am, it's around 25 minutes, ma'am.
Okay. So now we move to the world population and a little bit with India. So what is the world population and the cancer burden? So the nice language here is global cancer burden. Um, and so I tried to get all the latest data for you. And it has been growing things have been growing. So, and the numbers have not changed too much in terms of millions. So, incidence and mortality, these are two favorite words that are used in epidemiology. So right now we are studying epidemiology. Epidemiology means, what's the incidence uh, throughout the world? How many people die? How many people get cancer? So incidence is how many cases appear every year. So as of 2022, all right, the data was compiled in 2025, but it comes from 2022. Is that okay? So it comes from 2022. Um, but it was just done, let's say, last year and this year. So about 20 million new cases all over the world, have been diagnosed. Um, And there's probably there are many that are undiagnosed as well. But anyway, on the record, there's 20 million cases. And deaths. So after incidents, always first thing is incidents, how many people get it, and then how many people die from it. And mortality is about 9.7 million. Okay, so close to 10 million of people die worldwide in 2022. So we're expecting in by 2050, the um, epidemiologist, their job is to calculate and based on the curve and to see how many by 2050, how many there will be, and they're thinking that it's going to be 35 million, which is going to be much more. And a part of this is because of population growth, not because people are just going to get more and more cancer, but population is also growing. And so, bad story is that 1 in 5 people might develop globally will get cancer in their lifetime. And a further bad story is that men have more cancers. Men die more from cancers than women. So 1 in 9 men will die from cancer worldwide. Okay, and 1 in 12 women will, slightly less, have chances of dying worldwide from cancer. All right. So, males, so the take-home story is that males suffer more, a bit more than females globally. And and then that for both sexes combined, about 20%, okay, globally have the risk of developing cancer before the age of 75. Now, we all know that the longer you live, there will be more cancer because cancer is happening because of time of genetic mutations that accumulate. So the longer you live, there will be more cancer. That is a known fact. So anyway, I compiled this for per 1,000 people, for 1,000 people in males, just to show you that there will be a mortality of 110 deaths and versus 77 deaths in in males versus females. Okay. But the bottom line is that there is, in both sexes, there is 94 deaths for every 100,000 people. For every 100,000 uh, people who have been in the world, there will be, who are diagnosed with cancer, there will be 94 deaths from there. So, which is the five most common cancers worldwide? If you're going to work on cancer and you're going to do machine learning or AI, you need to know which are the top cancers. And so lung cancer is the major cancer that is the leading cause of death. And lung cancer is diagnosed also a lot, but when it's diagnosed, sometimes it's too late, and so it can cause death. Then is most prevalent is breast cancer in women, but colorectal cancer might come up first. So colorectal cancer in both men and women. And in men, prostate cancer, but if diagnosed early, then that's fine. I think I have notes in a bit in the next slide for you. And skin cancer, non-melanoma skin cancer. All right. So lung cancer is the worst, okay, globally. Um, So if I come look at men and women and children all together, then for men, it seems that, these are the three. So men, and I put in here prostate cancer. So the men can get diagnosed with prostate cancer more, but they will not die from it. So it is the most common cancer, right? So men have more prostate cancer and lung cancer and colorectal cancer, but that's another question of what they die from. They die more from lung cancer. Okay. So that is causing death, but this is more common cancer. Which cancers do you just get? Women get breast cancer. They will also get lung cancer and colorectal cancer. And so they can die more of lung cancer and uh, they can die more of lung cancer only because it's just hard to treat. Okay, so also lung cancer here. Okay, again, top. In children, it is leukemia, Okay, like I said, a lot of ALL, but there is other leukemias as well. And then there's brain tumors, okay, and lymphoma. So lymphoma is of the B cells. And so these are the major in children. This can be treated well. This is a good, this is a good treatment. They can be treated and cured. Brain tumors also fairly childhood cancers. The earlier they're caught, they are fairly treatable. But ALL takes so far is one of the good ones that has been 95% successful. Even the other ones. So in children, if it's caught early, and remember they're generally acute, they can be treated well. So where do we find these regional variations? Where do we find these cancers? In which countries? Okay, so regional variations in the cancer burden. Where do we find them? It so happens that there is in the developed countries, that there is a higher incidence, okay? There's a higher incidence um, in developed countries compared to the developing. So developing is really your third world countries, and the developed countries would fairly be your Western world. So there's a higher incidence. But I want you to pay attention to this word, age standardized rates. So if you pay attention to this word age standardized rates, that means the meaning is that people at various ages catch the cancer, right? So some people are young, some people are much older, and so they kind of like standardize, and they will say that, well, a young person counts as a young person catching the counts as a much more acute position, or much more at a younger age is much more um, um, what is it? A younger person can count to be a much more cancer that is almost like having it for two people. But a older person who gets it way in their 70s, etc., accumulated many mutations, and it came to. So you have to standardize and all those ages, and then you get this data. So I just want you to understand that age standardized means counting all the young, those who got it early, those who got it late, those who were diagnosed early versus those who were diagnosed late. A lot of that to be considered. And that's the science of epidemiology. And so higher incidence in these developed countries, okay? So what is it linked to? It can be linked to lifestyle, what you eat, what you breathe, etc. Then infections, did you get any viral infections, etc. And then did you check, are you checking your mouth, over often and screening? So, for example, therefore, you have in developed countries, you have more of prostate cancer and breast cancer. All right. So breast cancer is kind of mostly hormonal. A lot of it is mostly of hormonal origin. So, but there are some cancers that are very aggressive. Have you heard of triple negative breast cancer? Triple negative breast cancer is very aggressive. That is not hormone dependent. And so these are there much more in the developed countries. And so they can be diagnosed early. But in Asia we have higher of liver and stomach cancers, and that could again be lifestyle, etc., etc. So let's look at that. So in females, okay, I put this whole graph up for you. Let me just make this small so you can see. So in females, all right, so breast cancer, as you can see that in females, breast cancer is present in is the incidence. So this is incidence and this is mortality. So diagnosed. So every year there's huge amount of diagnosis for breast cancer. See the pink one, and so this is the dark one is cervix. I don't know if you can see it, but cervix in South America, Southern Africa. So you see here breast cancer in the North America, and then you see breast cancer also in India, right? So incidence, but mortality, there is not much of mortality from breast cancer. Okay. So breast cancer, the mortality is in India. So I'm circling, oops, I'm circling. So in India, the mortality, so there was more incidence and mortality. But look in North America, there is not, not so much mortality. The mortality is from lung. See, the mortality is from lung. So lung gets diagnosed late, and so there are more deaths. Breast cancer screening early, less death. But in India, breast cancer, whatever it is, it's not, as much as the US, but whatever it is, if it's diagnosed, the survival is also kind of like poor. So, all right, so just to tell you that there's lung cancer in about 23 countries. So look at this lung cancer, death by lung cancer in the North America, all right, in China. So also in the UK and in Australia, death by lung cancer. So therefore, lung cancer seems to be really the deadliest, one of the deadliest cancers. And that was in females. And in the same story is in the males. So in males, again, look at this incidence and mortality. All right, how many die and how many people get it. So again, prostate, huge amount of prostate diagnosed, lots of being diagnosed. But do they die of prostate? No, the males, they don't die so much of prostate. Again, they die of, they die of, they die of lung cancer. And that's the North America. Okay. I see that in India that there is stomach. No, this is not stomach cancers. So this is the in thing. And I put this oral green. Oral cancer is in green. So look at India. Oral cancers is the highest, one of the highest. I think the other places very. I mean, India is the only place that they have a huge amount of oral cancer. And so again, also in India, look at this death also from oral cancer. Alrighty. So and death from oral cancer also same way. So I will not go into the details of the other ones, but just to show you that lung cancer is for mortality. So you can have males do get prostate cancers, etc., but they don't die from it. Okay, so that means detecting prostate early is good. Detecting lung, of course, if possible, early is good, but it's just not so easy. And oral cancer. So we have a job to do. For India, we really have a job to do. For India, we need to have quicker, more screening for oral cancer, more screenings, regular screenings for oral cancer. So in total, what are the four deadliest cancers? All right, so lung cancer it seems. All right, and then it is colorectal, colon and rectal. Okay, so I cannot recall if I put that in here. So let's look at colorectum. Colorectal. It seems that colorectum is here, and so we have certain parts of Africa, incidents, a huge amount of Saudi Arabia, and also death from that as well. So the death numbers are just it's colorectal once it is diagnosed, the survival rate is poor. So they're deadly, okay? So they may not be until they're extremely deadly. So lung and colorectal. And the next one is breast cancer and pancreatic. Okay, so breast cancer and pancreatic. Pancreatic problem is that the survival is only 6 months, 2 months to 6 months. The pancreas, it's just soft tissue, hard to, find. And you find it when it's too late. So if you look at the survival rate, which I just told you for pancreatic is 2 to 6 months. then that ranks first. Okay, if you were looking at deadly, then it would rank first. And malignant mesothelioma, this is for the lungs. Okay, so this is for the lungs. Malignant mesothelioma takes place in the lungs, and so these are, survival rates are poor if it takes place. So malignant mesothelioma from asbestos, etc., exposure, environmental exposure takes place. Which are the five most treatable cancers? The five most treatable cancers are prostate. There you go. Okay, men can have prostate cancer, but it gets treated well. Thyroid cancers, testicular, skin, melanoma, and breast cancers. They are treatable. You can treat them. Breast cancers required um, these are dependent on hormones, so you can just treat them, and they are mostly curable. So good to know. So for you as students, again, if it's preventable, it's treatable, and it can be caught early, then maybe focus on these cancers much more than on the deadly ones. And so which ones are really, you have to keep treating them. They're not really curable. They're very hard to treat. The language is they are difficult to treat. That's the language. Okay. They are difficult to treat. And so that is your CLL, again, leukemia. See that? CLL, leukemia, blood cancers. All right, so CLL, CML, uh, myeloid leukemia, lymphocytic leukemia. It cannot be, you cannot, just because I taught you today does not mean you can remember every one of them. That's fine, as long as you just remember the broad picture. And liver, pancreas, and ovaries, these are also very difficult to treat cancers. Okay. Secondary breast cancer, that means the cancer was there somewhere else, but it now migrated to the breast. So, and which is the most painful cancer? I don't know why I thought that you should maybe just know that. When the cancer spreads to the bone, all right, okay, when the cancer is in the bone or spread to the bone, those are very, very painful cancers. Anindita, can you remind me if I have do I have 5 more minutes? Or is time over? Oh, sorry, Pooja, not Anindita.
Madam, you can proceed 5 to 10 minutes extra, no issue, as per your convenience.
Thank you. So to prevent cancer, one has to understand, one has to understand, like, if they're going to be diagnosed, then what are the risk factors? Our job is not to always look for screening and etc. But if we can identify the risk factors, then a lot of the measures can be taken, and then that is another way of prevention. So prevention is to identify risk factors, and prevention is screening. And screening is where you and we are here today, because we would like to talk about, image analysis, etc. So, in so so these are very well diagnosed. Lung, colorectal, and prostate. They are commonly very, very well they are diagnosed. They're not diagnosed early, but they are diagnosed. Okay, that's the incidence. They're just much more. So, to reduce the cancer burden, so we need to talk about the risk factors before we talk about anything else. Okay, so cancer patterns. So here's a couple of things is that in males, okay, so I'm going to talk about males, and I don't need to read this whole slide out. It's just to give you an idea that in sub-Saharan Africa, like in Africa, and based on socio-economic conditions, all right, prostate cancer can be found in the African countries, all right, but in the African countries, it's the leading cause of death. So disparities, the word is disparities. Large disparities means socioeconomic conditions, um, availability of resources, low resource settings. All right. these are just the all of these make this disparity is so big. The disparity means that availability is so poor in these countries in Central America and Sub-Saharan Africa that they die of prostate cancer. They didn't have to, but they they die. So that's one, is that maybe the detection is not there. All right. And lung cancer, which is very, very highly fatal. Okay. So in most countries, and again, those countries that have, in 89 countries, it is the leading cause of death, lung cancer. All right. But, it is commonly diagnosed in 33 countries, commonly diagnosed. So that means in the Western world, if it's diagnosed, they survive better. But in the other places of the world, they just die. So, okay. So the second thing is that, okay, and anyway, secondly, it has a high fatality rate. Lung cancer is just hard to survive, but still they do better in Western countries. So liver cancer, same thing. Liver cancer in all of these Southeast Asian countries, all right. It's the leading cancer of death in some of these countries, but it's not such a common cancer. But if they get it in these countries, they the mortality is high. So this again shows you that there is something like lifestyle. There's something like maybe diagnosis is not there, or maybe they're doing something, or they're exposing themselves to certain carcinogens. These are disparities. And of course, you have India and Pakistan, and in which pan, okay, we take pan. So lip and oral cancer is like huge. Okay, probably the only country in the world, two places in the world where we have oral cancer. So this is more cultural. So betel nut is betel nut, the thing inside the pan. So betel nut chewing inside that's inside the pond, that is it, that causes. And then those things called as jorda and all that other stuff that is inside the pond, not the pond leaf itself, but whatever we use inside it. So those cause cancer. So India, a nice comparison. What are the common cancers? Okay, common cancer is oropharynx, that means oral, simply oral. All right, esophagus. Esophagus is the top part, okay, before the stomach, and then the stomach. So these two cancers, again, maybe diet, food, and respiratory tract, okay, lung cancers. Um, Female, for women, it's mostly the breast, cervix, and again oral. Oral is always there for male and female. And so yes, people also put in tobacco. Tobacco, they chew tobacco, they take snuff, they put it in their nose. Snuff is I can't remember the word now. So, so because of this tobacco and BD, the BD and tobacco and all that, so it's all of that reasons that even in females also, farming women also use that. So, and then some of the remaining cases are breast and cervix, right? Compared to the U.S., where it is mostly skin cancer, lung, and prostate. These are the common cancers, not necessarily death. Breast and colorectal cancer. So, mortality is on the decline, etc. But again, let's look at this disparities. The Native American population is the Native Americans um, population, and the Black population, the African American population, they are at a higher risk for certain cancers. So, for example, the African American population or the Black population is at a higher risk for colorectal cancer. Young men at the very early 30s will develop colorectal cancer, and it leads to big mortality. Okay, so racial groups are also ethnicities and racial groups um, lead to death, etc. Okay, so now I do not want to spend too much time on this because I think I'm going over. So cancer patterns. So you don't have to just screen them. You should understand what is the etiology, means what is the reason. That means what are the risk factors. Okay. So what are the risk factors? And these are the risk factors: environmental, food, habit, genetics. And so I will kind of like show, in short, I will kind of like end it kind of here. Environmental factors are, carcinogens that are in the environment, pollution in the environment, within the environment, pollution, etc. Lifestyle, if you're in your lifestyle, you are eating an unhealthy diet, you're eating too much animal fat, too much, like in the Western world, too much beef fat. Then use of tobacco, like we just said, or smoking, etc., pan, etc., those can cause that. You can inherit genetic mutations. Women who have BRCA1 mutations, they will pass it on. Some viruses and some um, fluke, schistosoma fluke, can also cause cancer. So virus is the HPV virus that causes cervix or cervical cancer. And so certain diseases that are associated. So let's just go through these just in like 2 3 minutes, 2 minutes, and we're done. So tobacco, we already said that, right? Tobaccos and beauty. Excess alcohol, it can damage your liver and it can cause this also. Beer consumption, it is maybe. You see this language? Maybe. We're not very sure, but can cause rectal cancer. Then people who eat smoked fish. By the way, we are in Tripura, right? I also eat not smoked fish, but I also take, what is it, salted fish. So your shutki mach, right? Those also, these can also, they're very highly salted. That thing like nona elish. Too much intake, not in moderation, everything is fine, but too much intake can lead to stomach cancer. So in India there is stomach cancer, but not everybody takes all that fish. Now there are some controversies. There's a stop project recently that has a controversy and just says no, smoked fish does not do that. So all the um, salted and shutki mach kind of items, those are the ones that still it's running a controversy. Then, like I said, too much fat in the meat, okay, that causes intestinal cancer, colorectal cancer, sorry. Then too much fat can cause breast cancer. All right. Occupational, okay, radiation, occupational, outside, dust, all kinds of certain dust, and then all the chemical carcinogens can cause that. So, which is the one? Exposure to these arsenic, cadmium, vinyl chloride, asbestos. Asbestos is a construction material. So, people who are breathing dust from construction material of asbestos, they get lung cancer. And this is a big thing. For example, in USA, all the asbestos is being taken apart, and they take very precaution to make sure there is no asbestos in the materials. Vinyl chloride, again, construction materials. Polycyclic hydrocarbons, these are all in the environment for plastics, etc. And these cause cancer on a many year basis. Okay. So these do lead to cancer. Just showed you that UV rays, radiation, skin cancer, etc. in this figure. And virus. So viruses can cause liver cancers. Viruses can cause um, non-Hodgkin's lymphoma. It's just a list just to tell you that viruses can cause cervical cancer. We already know that. We talked about that, right? HPV and so leukemias. And here's something. This is called as Epstein-Barr virus. It's called as the kissing disease. It's called as mono. It's called as mono, and teenagers will get this. All right, so it could be mono or the kissing disease, and very few numbers of such people later on can develop, a lymphoma, a type of blood cancer. Okay, some people can. So, parasites. This is schistosomiasis. Schistosomiasis is a fluke. Where's so fluke is a like liver fluke, blood fluke. These are found in ponds. So, have you ever gone to a pond and you came out and there was fluke stuck to the bottom of your feet? That's the one. Those are flukes. They can cause bladder cancer. All right, too much of sunlight, etc., depending like the UV rays of North America and up on the up above the above the equator and way above the tropical cancer, they can cause more skin cancer, but not so much the sunlight on the equator or on the tropical cancer. So certain types of radiation. So UV A, B, and C, different types of radiation. Of course, habits. So these are genetic factors. We don't need to talk about these today, but you will have these. You just know that there are BRCA1 genes. It runs in the family from mother to daughter. If there's a mutation, it will happen. RBC, breast cancer will happen. RB is retinoblastoma. A child who is born with retinoblastoma, it is cancer of the eyes. And in these cancer of the eyes, the child has to either undergo surgery and to take out the eyes or take out, these days, the surgery is so good that you don't have to take out the eyes, but massive surgery to remove the tumor. And APC genes, this cause colorectal cancer. Colorectal cancer. So AP genes mutations cause colorectal cancer, and um, if you have a mutation, then you're likely to get it by the age of 50. All right, Mongolian people develop some more of leukemia. So some of that retinoblastoma is only in children. This is retinoblastoma here, RB, retinoblastoma. And so I will leave the genetic factor for another talk. All right. And these are all basically known lip and oral cancers. Look at this in India, huge, huge amounts. Look at the color, all right, darkest, right, darkest. Okay, it's there in other countries, but we have the darkest, and it's also there in other African countries. Oral cancer, huge. The numbers are going up, okay, in males. This is 2020, associated with so many deaths. And so this is oral um, cancer incidence, how many people are getting it in this graph. And you can see that for some reason in males in the mouth cancers are actually rising. All right. And I want you to just remember one thing, that the data, this is not me saying this, but this is textbook saying that whatever data you see, mortality rates, death rates can be misleading. It's not me saying this. This is out there, that it can be misleading. Why? Because it's all adjusted to age. It's age adjusted. Remember, I said that it's age adjusted. And then the reason, other thing is that, well, maybe so one reason, like I said, it's age adjusted because different cancers arise at different times in the human lifetime. So the data adjusts a young person with an old person and just say, oh, well, they count them differently. And so because of this different age distribution, it is adjusted, and so that might not reflect the actual number of right cases. So, for example, how is it that in China, okay, that in China there is 6 times less, okay, has the lowest risk of breast cancer, China, according to the data, and the Western world has the highest risk of breast cancer. Okay, how is it that there is a six-fold difference? Okay, how is it that there's a six-fold difference? And so is it to say that China has six-fold less times breast cancer than the Western world, or risk for breast cancer? Well, it's just the reason is that maybe they're just not, screening is not done, mammograms are not done, you know, and so it's just not possible that this data is accurate. And so therefore, incidence and mortality rate have to be carefully calculated and not taken just based on this. And I think the rest is all about how to do prevention and screening. And so, breast mammogram screening, that is the Western world. Pap smear for cervical cancer, which we will talk about more later on today, is a extremely good way to prevent cervical cancer. Colorectal cancer in adults, you can just take the feces and you can look at certain um, the features in the stool, and you can do that. Okay, for screening, at least in older people. And in lung cancer, you can do a CT scan of a low dose to look for it. There is no other way. There's no other way to do it. And prostate cancer. Prostate cancer is a digital rectal exam. Do you know what that means? It means that a hand, digital means fingers. So the finger has to go through the rectum of the male in order to feel the prostate, and that's how the doctor will first know that the whether the prostate is enlarged or not. And of course, PSA antigen is a very, very easy blood test to do in order to test that, to look for that. And in India, particularly India, big time prevention should be considered in all the dental colleges for oral cancer. If people are going to take pan and betel nut um, and tobacco, that's fine, as long as they keep screening. And so the dental colleges, with all there needs to be opportunistic. You call this opportunistic. So opportunistic screening should be done by the dental college, where the students just check, and check as a clinical approach, and the students get experience, and all anybody who takes pan on a regular basis and tobacco on a basis can check for oral cancer, and so that would take care of that. And that's all I have to say. I'm sorry, I think I went over. I'm not sure. Um, so I will take any questions at this point.
Thank you, madam, for your valuable this second lecture, lecture two. Now I asking for any question related to the this lecture, please. So
Good
that
afternoon.
is one. mm,
I'm
Am I
happy to
audible?
take questions, later on throughout. Okay, if you don't have them right away, students, you can think about your question, and we can do the questions even a little bit later on also. So, and don't,
Good afternoon, ma'am.
yes, please.
Yes, Devoshmita,
Ma'am,
please.
yes,
Thank you.
I do have one question, ma'am. How long does it take to move from one stage to another?
Yes, we will talk about that a little bit. So some of the cancers are slow growing. So cervical cancer in women, that takes a long time. So from stage 0 to stage 1, stage 2, it takes 10 years, okay? It can take a little bit more. And so all one has to do is one has to just keep following the,
Ma'am, it depends on the growth.
yes, but it depends on the cancer also. So some of them are aggressive cancers, and those aggressive cancers will go fast. So it depends on the growth. You're absolutely correct. But let's say that it was already in just stage 0, stage 1. Those also grow kind of slowly. So for cervical cancer, it will take a long time before it breaks and becomes metastases. So it will be slow. So, like I said, the nature of the cancer decides kind of like which is fast and which is kind of slow. So, aggressive, some of the breast cancers are very aggressive. Triple negative breast cancer. I mean, I did not write that here, but those are aggressive. And the stages and the growth takes place quickly. So, you're right. Yes, the growth takes place quickly, and then the stages can move fairly quickly. So, triple negative breast cancer. Um, so all kinds So yes, it depends on the growth. It depends on the person's immunity. Um, but some of the cancers go slow. Some of the cancers, many of the cancers can go fast.
Okay. Thank you, ma'am.
Well, good afternoon, madam. Karthik here. The slow rate of increase of cancer is one cause why the fatality rate in India is going up. By the time people realize about their cancer diagnosis, it is too late, sometimes third stage, second stage. Is there a way out where we can figure out it in early stages to avoid the fatality rate?
Yes, actually, that's, as time is progressing, number one is screening, but there are small blood tests, at least for prostate, that can be done. PSA is a good measure, it's a monitoring measure. And so, age related, cancer is accumulation of genetic defects, right? Mutations. So
Yes.
if we know if a male is at the age of 50, time to get a PSA in the blood tested, time to get a for all males to get a prostate cancer checked. I mean it's all so much treatable. Not only treatable, it can be death can be avoided. But if that was never done and then time has passed, then it's going to be hard. So screening is the best way. And I think the youth, you need to come up with mechanisms by which you can encourage knowing when you understand the pattern, you know that this can be treated very early on. It doesn't mean they can go in their 20 at the age of 25 or 40. They have to go at the age of 50. So this is where you come up with schemes and policies have to be changed where people can, at the age of 50, they are told time to get a mammogram. Now, a mammogram is expensive, but time to do a self-analysis. So the awareness, that's the biggest thing. Awareness has to be there. That awareness must come in first. And so self-test for breast cancer, teach women how to do a self-test. Most of the cancers women catch by themselves. They have to be able to it's palpable. They have to know how to know that something is wrong. So that is the way to do it. So every cancer has its own, blood cancers, it's hard. But if it's an adenoma and a child has a swelling in their face, this just happens. They have a swelling in their face. It's some kind of a, benign tumor, but it's there. And so the awareness needs to be there. It cannot be just disregarded. But let's not talk about the children ones because those are the really hard ones. But I was talking about more of prostate, breast, and colorectal. For colorectal, also now there are ways by which, at the age of 50, you can check it through the stool, and so that needs to be made cheaper, and it needs to be done earlier. So this is the only way. I think more than screening, honestly, Karthik, it's awareness.
Yes, you're right, madam. But despite the awareness campaigns run by various stakeholders, for example, I suggested a lot of my friends to go for cervical cancer vaccine and then get the mammography done, even at the slightest suspicion. They were not coming forward, and most of them do not wanted to undergo the invasive process to find out if something is carcinogenic. So,
They need to be explained. It's how much invasive it is and how much it is not. So just doing a pap smear is not hugely invasive. They need to be explained that this is, the risks involved, and that requires the education. And a mammogram has some X-ray to it, but a mammogram, you need not do it every year. I mean, the guidelines say mammogram every 2 to 3 years, I think. But a baseline mammogram needs to be done. So you need to kind of like encourage to say that how much the risk to benefit ratio is. That needs to be explained. And we are also, the fatalistic side also. George, whatever will happen, what will be, that is slightly there. So I think it has to do more with being firstly being a little bit more aware and to explain the risk. And if it has run in the family, then that's where to take it on.
Also, there is a taboo in across southern India about cervical cancer vaccine, which requires an immediate attention of experts like you. Yeah.
The cervical cancer vaccine, um, in the Western world, children from the age of 15 to 20 are taking the HPV vaccine for cervical cancer, and boys are also taking it. So boys and girls both are taking it. And it becomes kind of like a policy thing. So if there is a little bit of policy, and then because of if there's a policy, then it the funds for awareness and the funds for education come along with it. Only then it will happen. So if it becomes a policy, if it becomes an administrative requirement, then it becomes also a requirement to educate. Then it becomes there's a requirement of a social worker who will explain. There will be education for that. Only then it will work. And HPV is fairly new, right? It's not, we don't have it for many years. It's maybe what, 15, 20 years now that we have it or less?
Yes, probably. And thyroid cancer, there's a rising trend in terms of thyroid cancer in India. Any
I have a feeling it's environmental. I don't have much thought about that, but I have a feeling that it could be environmental. And I do hear that thyroid is increasing, which is, um, I have feeling that there's some kind of exposure maybe. That is the possibility.
Thank you very much for your answers.
Thank you for your questions.
Thank you, madam, for the lecture 2 session. So there will be 1 hour lunch break. We will be at 2 p.m.
Okay.
for our tutorial 1.
So thank you to all, and thank you, Karthik ji, and thank you, Devoshmita, for this kind of interaction. So I am requesting all of you, all of the participant, maybe very silly question. You have any doubt or anything, please ask. Thanks a lot to all. So we'll meet again at 2 o'clock. Thank you.
Thank you. At this point, I think we will get off of Zoom for 1 hour, and we'll resume again, same place, same Zoom.
Thank you.